Thank you very much for the invitation to come here. This invitation came out of a conversation late at night in a bar in Norway somewhere last year, followed up by an email saying, would I speak for 10 or 15 minutes on ethics of LVADs? And lo and behold, I see you've got me down for half an hour on the program. So you'll excuse me if I show some pictures that aren't entirely connected with LVADs or ethics or heart transplantation. What I want to do over 10 or 15, maybe 20 minutes is explore the relationship between heart transplantation as it's currently practiced, perhaps from a UK, certainly from a European perspective, and how it interacts with LVADs. It's a rapidly changing field, and you'll hear probably from the next speaker a completely different set of opinions, which may be more up to date than my own opinions. But I'll do my best to entertain you. Heart transplantation has been never shy of ethical questions. Back in Christian Barnard's day, in London in May 1968 when the first British heart transplant was used, or Norman Shumway's later on the same year. These ethics around donors, and we're not going to go anywhere near that. We're going to talk about the patients we select, the recipients we select, and what are the appropriate criteria. A couple of weeks ago I was asked to give a talk in Birmingham entitled Cardiac Transplantation Was Yesterday's Therapy. And in a sense that's also true, although I modified the technique to say, if not now, then very soon it'll be yesterday's therapy. Cardiac transplantation has, of course, a very long history. This is the Cambridge team doing some experimental animal work on the veldt, on the savanna of East Anglia. The Mexicans got into the field at a very early stage. Certainly the concept of the non-heart beating donor was very foreign to the Aztecs. Heart transplantation has been nice to me. I've done well, I've traveled to all parts of the world, I've had some great holidays, I've had some wonderful evenings. So it's been a very good thing to me. And it's perhaps from that perspective that I'm talking to you today. I've also worked with some colleagues who are completely stoned when they're at work, which is... Okay, that's the introduction. The background is that we have an epidemic of heart failure. Even in the UK, we have tens of thousands of cases. We have many thousands of patients, increasingly elderly patients with serious heart failure. And on the other hand, we have a heart transplantation as a very, very successful treatment, but limited by resources. I'll skip through this. The problem with the resources is that the numbers we do are very small and getting lower. And this is the depressing picture from the United Kingdom. Total transplant activity up to 2008, we were down to about 120 a year. Very, very few numbers, way down from the heyday of 10 years ago when we did double that number. And if you just look at the adults, we're down towards about 100 transplants a year in the whole of the UK. It's not as bad in other parts of the world, but it is bad. These are the most recent Eurotransplant figures going to 2008, and you can see that they are well below 70% of what they were doing 10 years ago. And if we look at the international registry activity, again, the figures are way down. They're way down from the peak, and there is a restricted number of the number of transplants we can do. It is very much resource restricted. Survival is good. You've all seen this sort of figure. This is a good statement, that it's the gold standard. This slide was given to me by a cardiologist. It's the gold standard. No other treatment yet can provide proven reliability, good short-term outcome, good long-term outcome. No reliable alternative for the severely ill patients who now make up the bulk of those undergoing transplantation. A case report in the New England Journal, and you have to do something special to get a case report in the New England Journal, but this is from 2 years ago. It describes a patient who was running, half Ironman triathlons. Not even Mr. Graham can do those these days. 18 years out after transplant. That's the standard that succeeding sorts of treatment need to achieve. The alternatives have in general fallen by the wayside. Cardiomyoplasty came and went. Cell transplants, a few percentage gain in ejection fraction, big deal. Nothing yet there to interest us. Xenotransplants, huge amounts of investment, came and went. the pigs are still smiling. The other nice thing about heart transplantation, particularly if you work in a state-run health service like the United Kingdom, is that it is cost-effective. We have a national process for assessing new treatments, and we have a sort of level of somewhere between £20,000 and £30,000 per additional quality-adjusted life year. A good quality year is worth spending £30,000 for in the United Kingdom. And heart transplantation comes well into that range. I quite like the idea of looking across the board at the cost of new treatment, because it means I can defend the things that are cost-effective and worth doing, and I can defend them against the pleading of emotional pediatricians or emotional geriatricians who want to push their particular treatment. I know that the things I do, and it's the same across the range of cardiac surgery, are in general terms cost-effective, so I think it's a good thing. I've already told you that heart transplantation has got unrivaled late results, and we have a severe resource shortage. So in this setting, who are the best patients to transplant? Do we want to look at outcomes, or do we want to look at costs? And in a sense, this is where the ethics comes in, because most of us in this room would take a utilitarian stance. If you've got a limited resource, we want to try and achieve the greatest benefit for the most patients. And this question occurs again and again in transplantation, but it actually occurs in all areas of medical treatment, because all of us, to a lesser or greater extent, are going to be limited by resources at some stage, and transplant is just a good example of that. We can divide our patients into three groups. There are the ambulant. They've all got bad heart failure, that's accepted. There are the ambulant. There are people at home, in and out of hospital, fluid retention, in and out of heart failure. Those who are a bit worse. Those in hospital, on inotropes, maybe a balloon pump. And there are the dying, the patient who is not going to be here in 24 hours unless you do something like a ventricular assist device. Let me go back. The ambulant, of course, are going to be the cheapest, at least from the heart transplant perspective. Their overall medical costs might be quite high because treating heart failure is expensive, but from the surgical budget point of view, from the heart transplant point of view, they're the least expensive. They come in, they have their operation, they get better. The problem from that point of view of treating the ambulant is that you may not be treating the right patients from a medical point of view. And I will remind you of the Cockpit trial, now 10 years old, that looked at a large cohort of patients in Germany receiving heart transplants, looked at their risk factors before transplant, and looked at their survival afterwards. And you can go and read the paper, but the bottom line is that only those in the most severe cohort actually got a survival benefit from heart transplant. And that's because heart failure treatment is very good at keeping you alive, and heart transplantation carries a risk. So only the sickest of those ambulant patients actually benefit, and although they may be appealing from an economic point of view, they may not be the best patients to transplant because they may not get the appropriate medical benefit. What about the inotrope dependent? These are patients in hospital, and we've got a bit of data from this in the UK, because for the past 7 or 8 years we've had an urgent allocation system, and so we collected outcomes. And in essence, we looked at the outcomes of this urgent scheme, which allocated about 30% of all the hearts we transplanted to the very sickest patients. I'll take you through this fairly quickly. You can see that we transplanted on the left-hand side the great majority of them, and very few died before transplant, so they were well selected. They survived up to the time of transplant in most cases. And afterwards, they had a very good survival indeed. If anything, their survival was a bit better than the standard patients coming in from home. So they did very well medically. They were clearly dying. They had excellent survival, 90% survival. So from a medical point of view, they were the patients who had the most to benefit from transplantation. In medical terms, a very good cost-benefit ratio. They're still expensive, as we will see in a moment. And the final lot are the people who are dying, who are VAD candidates. And again, we have some data on them from the United Kingdom because we did a study looking at the cost-benefit of bridging to transplant. Now, this study, I have to admit, was done in the early part of the current century, and therefore is already out of date for a number of reasons. But it's an interesting illustration of where we were, at least until a couple of years ago. It was a national study. This is not an institutional report. This is not a manufacturer's registry. This is everybody in a Western country in a period of time. So it's real life statistics. We looked at VAD patients, we compared them with the inotrope-dependent patients, and we did a whole series of very good mathematical modeling. The senior author is a statistician. And then we looked at survival, and we looked at quality of life and cost-benefit analysis of that quality of life. And I will take you through this very quickly. But in a sense, that's the survival. And it reflects a bit of the technology that was around 4 or 5 years ago, and the thinking about these were sick patients. But the survival rate was only about 50% once you fell into the VAD group, compared with 80% if you fell into the immediately getting a transplant inotrope-dependent group. The survival after transplant, as reported in many series around the world, was absolutely identical. So getting a VAD was bad news. You were very sick. You probably wouldn't have survived at all without it. But it was not a good survival story, and it was hugely expensive. So we're looking, and this happens to be in US dollars, at about £90,000 per QALY for the VAD group. The non-VAD group, the inotrope-dependent patients, are quite expensive, but they just about creep in, depending where the pound is against the dollar, they just about creep into our £30,000 threshold. And the conclusion was that the VAD patients did not represent a good cost-benefit analysis. This was within the UK, and this was some years ago. The problem for me is that we did the same number of transplants. We spent a lot of money, $90,000 per added year. We got 5 years on average for each of them, a huge amount of money. And we did the same number of transplants. And what we were achieving with the VAD program was transplanting this group rather than that group, because we still do our 110, 120 transplants a year. And the bridge to transplant effort ended up with the same number getting the long-term benefit, but made the overall package much more expensive. And when we're all having our budgets looked at, that's a major threat to us. And I felt we had to look very carefully at whether we should be doing bridge to transplant in the UK with those devices and with those philosophies and with those patients. This is another way of looking at it. You salvage some critically ill patients. You lose a lot on the way. Sepsis, thromboembolic disease. Once they get to transplant, they do fine. As I've said before, the numbers of transplants are unaffected. It's a very expensive way of selecting a different subgroup. And I must have been making that point in the bar over some Norwegian beers, too forcibly to have been asked to come and speak here. Some caveats. The message is always mixed. I'm going to tell you about children. I'm going to say a bit about VAD patient selection, and of course, as you'll hear from the next talk, and I'm not going to intrude too there, the technology is progressing. The important philosophy, and the reason why we still do bridge to transplant in the UK, and it's still government funded, was that everybody perceived that philosophically it's a stepping point to the next stage, which is definitive or destination therapy. My colleague Mr. Hassan said, don't talk about children in the same breath. There are enough organs for children if you keep the kid alive long enough for it to receive the transplant. And his VAD program using Berlin hearts in children is very successful. And of course, they have very long survival, so the QALY cost is much more respectable. The other thing is that many of those patients in the early part of the century were getting BIVADs because they were the sickest patients, and often they are now being selected out. And of course, we know from lots of published studies that patients who need a BIVAD do distinctly worse, almost regardless of their era. This is a much more recent era. And the other thing is the technology's changed. There were some heartmates, there were some thoratex, what you might regard as first-generation pusher plate technology, the sort of technology that gave you these results in the rematch study, and the technology has moved on. This is a slide from Les Miller's paper in the New England Journal, looking at bridge to transplant with the heartmate 2, I think, and you see that the green curve shows some early deaths, but then it pretty much levels out after 6 months. Much less morbidity from the device. This is a device, I forget which one it is, but it's what we were using in Newcastle, which is where the slide came from. And again, similarly, much lower morbidity and mortality with the device. So the technology is changing all the time. And if you have, this is a patient who had a VAD in our institution a couple of weeks ago, he is clearly much cheaper than somebody on your high dependency unit coupled to an air compressor. He's walking around, and in fact he doesn't really want a transplant because he feels so good, and that's an indication of how good the LVAD technology has progressed. And a final slide from Intermax showing that the destination therapy group of patients who are sicker, regarded as too sick to have a transplant, are with the modern technology surviving just as well as the bridge to transplant. So the technology is almost there, and the pain we've gone through may be worthwhile. The message is that if you're setting out in a new direction with new technology, have a clear idea of where you're going. I'm going to finish my talk there. Thank you very much.
Have we got any questions from the audience for Professor Dark?
I have one.
Maybe after the next speaker we can have some questions.
No, actually, we have also a fairly great program with VADs, and for us the ethical problem is in a way that the transplant is the gold standard with a good outcome. That's no question. And if you have a couple of young guys and you have to gamble. Because you don't know how long it will take until he gets a donor. If you said, let's wait, the patient may worsen, may be unable to be provided with an LVAD technology, maybe he needs a BiVAD technology, and finally he drops over the edge and outcome is very poor. So there is, and the other thing is with the results, that you said the time has come for destination. I don't think so, because selection determines outcome, and that's especially true for VADs. If you only look for the good patients, it's fairly simple. You have excellent results. But if you take every patient, even if he's young and he's totally crashed and he has severe right heart failure, there's no good way out today. You can put him on an ECMO maybe for weeks. You can put him on BiVADs. But if you don't get a donor heart, the patient's going to die to a high percentage.
I think it's a constantly changing world. I think those VAD results from the UK came from a lot of BiVAD patients, early technology. They came from a policy towards trying to treat the so-called crash and burn patient. I must say my own colleagues in Newcastle are turning away from the crash and burn treatment patient. They're saying maybe these are not just salvageable. And that they are increasingly saying, let's put an LVAD into a stable patient before he becomes so unstable he then needs a BiVAD. So it's a different set of considerations. But I agree with you completely. We have sat and agonized on the young man, inotrope dependent, with a balloon pump, sitting up and talking to us. Do we wait for a heart, or do we go to the risk of the LVAD?
Yeah. We have also the problem, if I may continue, that our patients usually come very late. I want to have my patients early, and I prefer to do an elective LVAD implantation.
I'm sure our patients come later than yours.
We could. I'm not so sure. But anyhow, what we try to do now is just also for the sake of money, to put the patient on ECMOs or on biventricular, 2 separate rotary pumps. And if they recover for whatever reason, we then switch to an implantable or at least to an external BiVAD with much better outcome.
It's a question from Mr. Graham.
Yes, Prof. There's been a national review of transplantation in the UK that you participated in, partly on the back of the anticipation from government initiatives that there will be an increased number of donor organs. How potentially would that impact upon what you said today about the ethics of transplantation that you would take on?
It's the same. Whether you have 100 donor organs or 200 donor organs, it doesn't matter, because it's a drop in the ocean against 6,000 patients dying of end-stage heart failure. So it doesn't really matter how many organs you have. There are never, ever going to be enough for heart transplantation to be a really successful treatment for the population with heart failure. It may make it easier for the selected very sick young patient, because if you have double the number of organs, your wait is perhaps 3 days rather than seven days for the lucky few. But the same issue still pertains. Until we have good enough destination therapy, don't delude yourself to thinking that you're keeping more patients alive by doing LVADs. All you're doing is selecting a different cohort who go on to get transplant, and you're still spending a lot of money. Thank you.
May I ask you one very unfriendly question at the end? What about retransplants in children in the UK?
It's part of the treatment.
It's part of the treatment.
When we list children for transplant at the age of, say, 3 or 5 or 8, we regard retransplant as part of the overall package. The problem is that most of the retransplants we've had to do have been when the children become teenagers and stop taking their tablets.
So problems everywhere. Thank you very much. So